It's 6 o'clock now, so I think we'll start. Good evening, good morning, and good afternoon, everyone. I believe we've got people from all over the world here today, so I'm welcoming you in at whatever time of day it is. I'm Andre LeMay. I'm the co-editor-in-chief of the Journal of Research in Nursing, and it is my pleasure tonight to welcome you to the first JRN debate in partnership with the Foundation of Nursing Studies. This is the first time we've done such a thing, so we hope that the technology will run smoothly tonight. And if there are any glitches, we ask you to stay with us while we try and sort them out. And if for any reason transmission goes down completely, we hope it won't, please ring in again after 2 or 3 minutes. We're recording the debate tonight and we'll post it on the JRN YouTube channel, so you can see it again if you want to, or pass it on to others to view.
Good evening, I'm Pam Smith and I co-edit the Journal of Research in Nursing with Andre. I'm also a trustee of the Foundation of Nursing Studies. It was to be my privilege this evening to introduce you to Dame Elizabeth Annie Onwu, Emeritus Professor of Nursing at the University of West London. Dame Elizabeth was to open our event with some personal reflections on our topic. Unfortunately, she has been overdoing things of late and has been advised to rest. If you follow her on Twitter, you'll know that she was everywhere in her inimitable style promoting Black history last month. Quite understandably, she has withdrawn from public engagements until she fully recovers. So sadly, she won't be joining us in person this evening, but she is with us in spirit and sends us all her very best wishes. I am delighted, however, to advise that Dr. David Foster, Chair of the Foundation of Nursing Studies, has kindly stepped forward to both open and close our debate this evening. So without any further ado, I shall hand over to David to share some of his personal reflections of the significance of the topic our panel will be debating this evening. David.
Thank you, Anne, and it's a pleasure to be here. As they say, there's nothing like a dame, and I'm nothing like a dame, and certainly nothing like Dame Elizabeth. Dame Elizabeth, in fact, and I could not be much more different. Her career in the community and as an academic established sickle cell disease and thalassemia as a specialist area of practice. And she set up nurse-led services to satisfy that unmet need. My NHS career was mostly in hospitals, in adult intensive care and in management and leadership roles. After that, I was a Deputy Chief Nursing Officer at the Department of Health in England. So neither of us are strangers to the rewards and benefits of nursing, but neither are we strangers to the pressures and stresses. Although we are so different, and regardless of our sphere of nursing, there is always a relationship between workforce and workload and safety, between doing a great job and getting the job done, and between the culture and atmosphere in which we nurse. That heralds the importance of our motion, that this house believes that a natural facet of nursing work is that it depletes nurses' well-being. I not only look forward to the debate between our distinguished panels, but also to hearing how this complex set of relationships between workforce, workload, safety, and the quality of care can be addressed. Andre.
Thank you, David, for that wonderful rallying call. Before we introduce our teams this evening, a little technological housekeeping is necessary. Joanne Bosanquet, Chief Executive of the Foundation of Nursing Studies, and Louise Thrift, a JRN editorial assistant, will explain the procedures we'll follow this evening and how we'll use Zoom to support our debate and your engagement with it. So over to you, Joanne.
Thank you, Andre. In a moment, we'll be inviting you to vote on the motion, but first of all, I'm going to take you on a quick tour of the system. For those of you who will be using Twitter this evening, the hashtag is JRNTalk. So you should only see presenters on your screen. You can't see or hear any member of the audience. So in order for you to engage in this debate, I invite you to post questions you have for the panel through the Q&A facility. If you're on a desktop computer, the Q&A button should be next to the chat box at the bottom bar of your screen. If you're on a mobile phone, iPhone or iPad, the Q&A button is likely to be in a white box at the top right of your screen. If for some reason you don't have a Q&A function, please post the question in the chat box and we will move it over. If somebody has already posted a question that you rather like and you would like to be asked yourself, then please press the like button. This will ensure that the most popular questions are asked of the panel in the time that we have available. And if you'd like to respond to any of our presenters or share an experience that resonates with what members of the panel are saying, please use the chat facility. Lou and I will be monitoring this throughout the event, so please know that you can reach out about anything that we're discussing this evening and that raise any specific issues for you. And then finally, your own safety is really important to us, especially when we're debating such an emotive subject. So if anybody's feeling traumatized or re-traumatized at all during tonight, contact your usual support service or practitioner to have an adaptive conversation towards recovery. We've put a link to this infographic on the Eventbrite page, so that will help you. So I shall now hand over to Lou, who's going to invite you to vote on the motion.
Hi, I'm Lou. I'm the editorial assistant on JRN, and I'm running the poll. So the question that we have for everybody before we start the debate is, the motion for this debate is that the House believes that a natural facet of nursing work is that it depletes nurses' well-being. I'd like to either agree or disagree. Everybody see that? People are still voting. Up to 80% now. Leave it for another couple of seconds. Okay, I'm going to close the poll now. And I'm going to share the results with you on screen. Okay.
And over to Anne.
Thank you. Our first speaker speaking for the motion is Pam Smith. Pam is Professor of Nursing in the School of Health in Social Science at the University of Edinburgh and author of The Emotional Labour of Nursing, How Nurses Care, and The Emotional Labour of Nursing Revisited, Can Nurses Still Care? Pam is also the president of the International Collaboration for Community Health Nursing Research. When we hand over to Pam, she will introduce her team.
Opposing the motion is deBlok. Jos is a globally recognised keynote speaker, changemaker and visionary. He's founder and CEO of Buurtzorg, Neighbourhood Nursing. Jos too will introduce his team.
After Pam and her team have presented their case for the motion, and Jos and his team, they will present their arguments opposing the motion. Once our speakers have concluded, we will take a short comfort break, during which time you're encouraged to submit your questions using the Q&A facility Joanne has described, and remembering that the questions that get the most likes are the ones we're most likely to be able to raise with our panel this evening. But first, our speakers. Over to Pam and her team.
Good evening, everybody. We're absolutely delighted to be here with you and to propose this motion. But first, I'm delighted to introduce our truly global team. First, Gerard Brennan is a clinical academic mental health nurse who spends half his week in nursing studies at the University of Edinburgh and the other half in NHS Lothian as a nurse specialist in liaison psychiatry. Next, we have Daniela Castillo, a PhD researcher, also at the University of Edinburgh. She's an assistant professor at the University of Chile and has acted as an advisor to the Chilean Ministry of Health. Radha Adhikari is the third member of our team and is a lecturer at the University of the West of Scotland. She has significant experience researching nursing education and international migration and nursing on the front line in Nepal and UK. So first of all, I will present the evidence for this motion. This House believes that a natural facet of nursing work is that it depletes nurses' well-being. First, a few facts. Globally, nursing accounts for 59% of all healthcare professionals and 90% are women. Nurses are seen as central to achieving universal health coverage, meeting the Sustainable Development Goals, and to have a triple impact towards achieving greater gender equality, better health, and stronger economies. So high-level reports put huge expectations on nurses, compounded by a global shortage of about 6 million. Yet what is the nature of nursing work? Nearly 50 years ago, nursing and midwifery were declared the major caring professions. Yet much of nurses' work remains unnoticed, uncounted, and undervalued. Nurses' UK pay actually dropped 20% over 10 years. But nursing work only remains unnoticed until things go wrong. Then nurses become scapegoats for national scandals. So it isn't surprising nurses' mental health is suffering, and at breaking point, a headline which appeared long before the COVID-19 pandemic. So what is the caring work of nurses and why is it seen to be natural? Maybe because 90% of nurses are women, nursing is seen as just women's work. My own research showed otherwise. When I talked to student nurses, they conveyed a sense of the sheer hard work required to maintain a smile or stay calm to care for patients. Nurse leaders were vital because they set the emotional tone. As one student put it, they are critical because of their influence on the ward team and how the students work, the way they feel, their morale. When students knew their leaders cared, they felt a bit more at ease. When they didn't, they felt fear, which blocked their learning. Mutual respect was the best and supported them to do the little things to care for patients, to help their emotional side. Sociologists give a language to connect emotions, care, and women's work. Graham sums it up. When we talk about caring for someone, we are talking about our emotions. Hochschild developed the theory emotional labour to describe the invisibility of people work undertaken by flight attendants and others. Put simply, emotional labour requires induction or suppression of feeling to present an outward appearance of calm, to produce in others a sense of being cared for in a convivial, safe place. Emotional labour is exchanged for a wage and has commercial value. So why does the nature of nursing work deplete nurses' well-being? With respect to the current motion, the nature of nursing work depletes nursing well-being when their emotional labour becomes a burden and takes its toll not only on themselves, but also patients, colleagues, families. Although emotional labour has commercial value, a study of Canadian health services shows how financial targets limited nurses' decision-making, forcing them to go against their expert judgment, leading to conflict, dissonance, stress, and burnout. Nurses worldwide are always there, often working with limited resources on the front line of wars, political conflicts, emergencies, epidemics, giving extraordinary care for people at the extremes of life and death. The COVID pandemic accentuates these extremes to intensify the nature of the work, increase emotional detachment, burnout, PTSD, and deplete well-being. Yet despite this, patients recovering from COVID describe the extraordinary ways nurses cared for them. British author Michael Rosen talks about the letters of hope and support written by nurses which helped him survive. The pandemic reveals just what nurses do, but also exposes the inequalities of class, gender, race, and ethnicity, and the vulnerabilities of migrant and refugee communities. We must urge governments to recognise nurses' emotional labour, how it is integral to the caring economy and vital to gender equality, sustainability, and well-being. I now hand over to Gerard to second this motion.
Thank you very much. I'm in the fortunate position of occupying two roles simultaneously. I'm that weird breed of nurse, a clinical academic, working across the NHS and university. So already I think I shatter the normal perception of what nursing work is. And to discuss nurses' work and how it depletes well-being, which I think it does, we need to understand what that is in 2020. Nurses' work is not confined to the bedside in the medical ward, though that's where I do find myself some days. The majority of nursing work is not seen because it's what Davina Allen coins organising work. This involves information seeking, making sense of complexity, communication, and the use of information technology. It is therefore nurses interacting and negotiating with multiple systems at the same time in order to keep patients progressing within our health system. Indeed, often this work does not take place in a hospital, but out in the community, in people's own homes, in primary care settings, and even universities. The nature of this organising work will depend on people's specific roles. In my instance, it means assessing people in accident and emergency or acute medicine, often after they've harmed themselves. Or it means delivering learning to students, albeit in a more virtual setting these days. A lot of my job is making autonomous decisions about if it's safe for someone to go home or what supports they might need. It means assessing and working with risk. It means trotting down to outpatients to see people on a one-to-one basis to deliver psychological intervention. It means liaising with other parts of the health and social care system, family members, GPs, support workers, voluntary organisations, bed managers, community mental health teams, and even my own colleagues. All of these things are nursing work, and all roles have two things in common: relationships and structures. As someone who clinically delivers interpersonal psychotherapy, I can tell you that other people are the hell in our lives, but they're also the joy. We all know and experience this to some degree every day. Then why would it be any different for nursing, a profession that prides itself on the interprofessional relationship building? Nurses work, regardless of where they work with people, listening to their stories and trying to relate. And it's because of this essential element, this interpersonal nature of the work, that it is, in my opinion, is one of the risks to nurses' well-being. That is because often we end up listening to people when they're demonstrating very heightened levels of expressed emotion, and sometimes that's only our colleagues. But it is this emotion and the reactions that it evokes within us is the crux of the issue. The second risk is that this interpersonal dynamic is enmeshed within systems and structures. And often the distress which people express is down to the conflict between systems and structures, far beyond our scope of influence. Yet we remain the face of these systems, all the responsibility with none of the power. Indeed, that's because so many of the systems don't always function very well. And in lies the distress for nurses, because they see that there is a person at the centre of all this, a patient or a student. And often what is required of nurses is to engage in organising work for the sake of the individual, but come up against barrier after barrier. This frustration is what contributes to depleting well-being. And what is worse is that it is often invisible and not recognised for what it is, essential to keeping the show on the road. Indeed, Davina Allen herself states that the better this work is done, the less visible it is to those who benefit from it. I'm in the very fortunate position of having access to clinical supervision. And yet, despite the complexity and interpersonal nature of all nursing work, the majority of nurses do not have access to this. In the UK in 2020, this is still not mandatory. How many of my academic colleagues are provided with supervision on their supervisory relationships with students? Nurses, regardless of their setting, enter into helping relationships every day, which bring all sorts of trials and tribulations. Yet we do not talk about this or have formal supervision ourselves. The issues, therefore, remain invisible and unacknowledged. And it is this constant invisibility of nurses' interaction with the interpersonal and the structural that means our well-being is constantly being depleted. I'll now hand you over to my colleague, Danny.
Thanks, Gerard. Imagine a 2-year-old boy is admitted to hospital for routine tonsillitis and develops severe infection and acute kidney failure. He spends 9 weeks in intensive care, is on dialysis periodically, worsens each day, the infection spreads in his little body. Surgeons amputate different parts to save him. His family is devastated. He's their only son, previously healthy. After an intense couple of weeks, the once friendly and supportive nurses, one by one, disappear. Now, imagine you are a nurse, and it is your job to dialyze this boy, not knowing which part of his body was mutilated on the previous shift. You must coordinate the procedure with the rest of the team, monitor treatment response, make critical decisions, and make heartbreaking phone calls to the family. You must also be present and take care of other patients and families considering their needs too. Where do the nurses go? In this particular case, the emotional stress and tension manifested in physical ailment, rendering 60% of the team out of action. I was the nurse who called the shots, coordinate treatment and dialyzed that boy while my colleagues couldn't cope. As a professional, my default coping mechanism was emotion suppression by working overtime as I cover for my colleagues. But even then, I remember that feeling in my body each morning. My stomach was tied in knots, not knowing what new disfigurations or decisions I would face that day. I felt guilty because I was not physically, not emotionally capable of giving the best quality of care that I knew was needed. When it was all over, I went home with all that burden, trying to get on with life as if nothing had happened. Where in the hospital policy or guidelines does it say how to cope with seeing a 2-year-old child being taken apart piece by piece? There is no hospital policy or guideline to support staff in such circumstances. From Banting, author of Labors of Love, and the emotional labor and the provision of compassionate care is painted as cost neutral. It is up to the team to reflect and handle the situation individually. Nurses have a permanent internal negotiation between their own beliefs, values, emotions, and the demands of the organization, the needs of patients and family members, as well as their expectations of the care they want to deliver within a context and in relation with others. Beyond this, the nature of our work is complex, emotional, as well as rational, embodied, desiring, and profoundly relational. During my professional life, I've held senior level positions in nursing across various institutions in the hospital system, in the ministry, and in universities. Ironically, in each of these roles, I felt like a novice at times when exposed to extreme situations, mainly at the emotional level. The case I mentioned earlier exemplifies the complex nature of the clinical work that is experienced daily by nurses. But situations like this continue to raise questions such as, how can we live with dissonance and learn from it? Who are the experts when dealing with impactful emotional experiences? The emotional labor of nurses has clearly been exacerbated during the COVID-19 pandemic. On top of this, each country has its own crises and grievances. For example, Chile has been undergoing political upheaval for the past 12 months. Together, this intensifies pressure on the system and the staff. Now more than ever, nurses are experiencing rising fear, anxiety, exhaustion, frustration, and anger. There is much uncertainty and confusion on how to manage relationships altered by the pandemic. And it is within these relationships that the nursing work is lived. Unless there is movement in the definition and visibility of nursing work, and systemic change in the expectations of care and support of nursing emotional labor therapeutically, then dissonance and depletion will continue to strike workers. Now I'll hand over to Radha.
Thank you. I share my personal and professional experience to support the motion. I've been a nurse for over 30 years now. I've worked on the front line in Nepal, also in the UK. About 22 years ago, I developed a rare and very complex eye condition that left me blind in my left eye. Then I had like 3 months old baby, and going blind was absolutely terrifying. And I got so scared. And my doctor told me that it could have been due to my prolonged exposure to patients in the hospital setting where I worked. And I worked in medical ward, looked after TB patients. And I got so scared, I started exploring if other people have similar experiences. And I learned that there was a nurse in the same hospital who also was going through the same. And just trying to further explore what happens to others. Is it just in one hospital in Nepal, or it's a wider issue? And I learned that this is a global issue. Occupational risk. We are exposed to infection, catching infection from patients, as well as other stuff. And I learned that nurses are exposed to two major occupational risks. One is catching infection, and other one is a long-term, like ongoing emotional burnout. I was just trying to understand what emotional burnout is then. And I just reading through, I have many examples, and talking to people, I learned a lot about it. Just recently, I was talking to a nurse, my colleague in London, and she was working on the front line during the early period of COVID pandemic. And she manages a ward in a busy London hospital. And one day in mid-September, just recently, I was talking to her after she got back from work, and she said she was absolutely exhausted. She explained to me about her working environment there. Because there is a shortage of nurses on the ward. Many people have gone off sick, and some are in quarantine. And those who are left there will have to manage everything, cover extra hours and do extra shift. And they all feel exhausted. And she said, I don't know, I feel so tired. How long can I go like this? And she's right, absolutely. How long can anyone go like that? This is not just her story in this London hospital, but it has been published just recently in Royal College of Nursing website. There is a survey report which suggests that there is lots of nurses and ready to get burnout and future nursing workforce crisis. Just looking through the evidences in other parts of the world, I found an article, it was a survey article done in 2018 in China. As many as 64% nurses working on the front line experience slow occupational burnout. This was due to work pressure, basically, and so staff shortage and working in a highly pressurized environment, and an emotionally tiring job, basically. And how long can we go like that was their concluding point. Nursing shortage is a global issue. We heard lots of stories of shortages and PPE shortages during the early stage of pandemic in the UK, but that is everyday reality for nurses across, particularly in low-income countries. And there is a risk of catching infection, which has not been adequately addressed. An unsafe working condition is because of these issues, and nursing, once a job for life, is not so anymore. And nursing, like leaving job, early retirement, and also going on sick leave for long-term illness are common. For example, in 2018, almost 25% student nurses in the UK didn't complete their training. Why? Once they are exposed to the real world of nursing, they're not sure they really want to do that anymore. And these are issues, but what we hear in media and television and politicians say is like nurses are angels, basically, and NHS heroes, and we saved NHS. And recently there was a small article published in Los Angeles Times just about a month ago, which featured nurses from around the world, from so many countries, and working on the front line and fighting, looking after COVID-19 patients, saving their lives, and featured as heroes, again, coronavirus heroes. What I really want to say is, we're not really coronavirus hero, we're not angels, or we're not NHS heroes, we're not invincible, we're also human being. We have social life, family life, and we are also vulnerable. And so much of our work is emotional, and going through all that and work in very pressurized environment, which is not adequately addressed. All these factors definitely challenge our health and well-being. I now hand over to Professor Pam Smith. Thank you very much.
Thank you, team, for that very strong message. To support this motion, this House believes that a natural facet of nursing work is that it depletes nurses' well-being. Garode reveals the importance of systems to support nurses' mental health and build their resistance and resilience. Danny emphasizes the joy and burden of caring and the risk of dissonance. Radha describes the personal, physical, and emotional costs of caring, which depletes nurses' well-being. She reminds us nurses are human, and therein lies our humanity and commitment to and cost of care. I now hand over to my colleague, Jos deBlok, to oppose the motion. Thank you.
Thank you, Pam, Gerard, Radha, and Danny. Jos, over to you now to introduce your team and to present your case against the motion.
Yes, thank you very much. And we are very proud to be part of this wonderful debate. Very important. I first want to introduce Judith Verhoef. Judith is a nurse specialist. She started to work as a nurse at a very young age, I believe. She's still very young, but she already has a very experienced career. She's working, doing projects. She's still working as a community nurse. And she's a very inspiring young woman whose view on the world is very hopeful for the future. You will hear from her more. And of course, I'm very proud to also introduce Joost deBlok, same name, and perhaps also some similar characteristics. Joost is my youngest son. And although he's just 27, he already works for 10 years for Buurtzorg. And he started to work at the office and he became a community nurse. And he's also, like Judith, doing some projects. And I'm very proud that I am the past and they are the future of nursing. So first, I want to start with my own experience. But after my study economics, 2 years, I quit my study and I wanted to become a nurse. I did some holiday work in 1976 in a small hospital in Holland. And I thought this is a very meaningful work, very relational, and everything you do means something. This led to that I started to study nursing in a hospital. And after that, I did my bachelor and I became a community nurse. And this was 1986, 1987. And this was in a period that community nursing was on a very high level, not only in Holland, but also in the UK. I had some colleagues from the UK coming over to Holland, and we talked about our profession and how important it was what we were doing for society. And how important it was that we had our own autonomy. And in this period, there were several researches. There was also research in the UK. In December last year, I had handed over by Lady Cumberley in the House of Lords. And she showed me the research which was done in 1987 in the United Kingdom. We also had a research in Holland in that period. And that showed that becoming community nurse was the most healthy profession in Holland. And you could see at the sickness rate, which was only 3%, that autonomy, high professional skills, freedom, and support by colleagues were the most important indicators for this healthy profession. Also in that period, the profession had a big variety of activities. So it was not only nursing care, but it was also prevention. And there was a lot of autonomy. And at that moment, we didn't have any managers or leaders. We were the leaders ourselves. So and that changed and disappeared in the 90s. So in the 90s, new public management was introduced all over the world. And new public management made us think that we should see healthcare as a product, as delivering products and activities in minutes. So efficiency became the most important factor indicator of doing good things. KPIs, we didn't know what KPIs were, but then suddenly we were confronted with management layers, with KPIs and with all kinds of things which has nothing to do with the relationship we had to build with our patients. So what we saw in 10 years' time, that there was a really kind of breakdown of the profession. And what we saw in 2005 in Holland was that 50% of the nurses left their jobs in 10 years' time because of the way the healthcare was organized. And it was mainly in community healthcare, but this was also in mental care, and also this development was going on in hospitals. At that moment, we decided to change things. So we said, as nurses, we know how we can improve the system. The system needs to be healed. We are nurses and we are healers. So why shouldn't we start something completely new based on the principles of the past? So inspired by the 80s, the 70s and 80s, we started with Buurtzorg. And within some years, we grew from 4 nurses to 10,000 nurses. It was a revolution. And every time again, it were the simple principles, the same principles every time again that the team wants to start. It was having the autonomy to decide what to do with the patients you were responsible for. It was choosing your own colleagues, working with colleagues who had the same vision, the same intrinsic motivation, to make it enjoyable and to share the support with each other. This was an amazing experience, and we simplified the system. We said delivering healthcare is not a product, but building relationships is important. You should have time to build a very trustful relationship with patients, and then the outcome will improve. And that's what we showed. We showed that the outcome, not only on quality, was much better than what we had, but also the volume decreased. So the pressure on the capacity decreased. So we showed that by just doing from our professional ethics what was needed, we showed that we could do less with less time, deliver more quality, even till 40% less time. So for me, this experience from the last 40 years showed me that we have to learn from the past, and we have to create conditions that nurses can work based on their professional ethics. So what we need is autonomy. So we need to decide, we know based on our skills, we know based on our education, and we know based on our profession, what are the important things to do with patients. And together with patients, we decide what are the things we need to do to create quality of life and to improve the life of elderly and people we take care for. We need supportive colleagues. We need an environment which is stimulating, not frustrating. So why should we accept all this bureaucracy? Why should we just do what everybody's asking without any reasons? I just had a meeting today with an organization who is representing the health insurances in Holland. And our Dutch Minister of Healthcare introduced something new bureaucracy. And they asked me, what do you think about it? And I said, I said to them, why are we doing this? What's the reason? And they said to me, there is no reason. So I said, don't do it then. So I think we should, as nurses, take a position in all kinds of discussions and not just do what we are asked to do, but commit ourselves to what we started to work for as a nurse, commit ourselves to the patients. So we need a revolution. We need that nurses, when they are 67, can say, we had a wonderful career. Last week, I said goodbye to a nurse who was 75. She ended her career now because of COVID. She thought it's becoming too risky for me, but she was 75. She said, I worked more years than I needed to because I enjoyed the working so much. So that is possible. So let's create systems, let's create structures, let's create environments which makes it possible for nurses to have a wonderful career, to enjoy their work, to grow, because sometimes it is really heavy, it can be heavy. We are doing a lot of things which creates emotions, but by sharing these emotions, we grow from it. So this growing perspective, that's something that I really want to support. We are working now in 27 countries and all over the world. I see the same. There's one thing especially from the UK, I remembered from 10 years ago. 10 years ago, I was in London. I was invited for a conference organized by KPMG, be aware. And in this conference, we had a kind of an evening before the conference, a dinner with important people. And I still remember there was somebody from the House of Lords. I don't know his name anymore. And I was telling during the dinner what we were doing in Holland. And what he said was, nurses in the UK are not able to do this. I was surprised that this quite old man was talking this way about nurses. We should not accept it. I said to this man, I think not the nurses are the problem, but your perception of nurses is the problem. This is the way we try to control nurses, and we nurses, we don't want to be controlled this way. So he was quite angry when I gave him this answer, but I remember it still. It was 10 years ago. So I hope the coming 10 years will be more hopeful. I disagree with what's been said about that the work of nurses is depleting. And I really believe that it's a very meaningful job, one of the most meaningful jobs you can have. And the circumstances you're working in is creating pressure or is creating a growing experience. And then I want to hand over to Joost. Joost is going to tell something about his own experience as a nurse, and let's listen to him.
Yes, thank you, and good evening, everybody. Tonight, I have heard many times nursing is emotional labor, and I agree. Nursing can be emotionally heavy. I remember well that during my internship at Buurtzorg, I had to care for the first time for a terminally ill patient. The patient would not allow us to help him because he was embarrassed that he needed care and thought his wife should help him with it. His wife, however, could not handle the situation anymore. She was overloaded. An experienced colleague explained to me how I could support the patient and his wife. As time went by, the condition of the patient was becoming worse. In the meantime, we, our team, gained the patient's trust and could deliver the necessary care, and his wife was no longer overloaded. After a while, I was able to have conversations with the patient about his life and about what was important for him and his family. Also, we spoke about what he still wanted to do with his time left. So the illness was becoming worse, but the ambience in the house and maybe also the quality of life improved. The last time I saw him, he said, "Joost, my friend, thank you for everything," and that it meant a lot to him. 2 days later, he passed away. His wife and son thanked our team and said even though it was a sad situation, they could enjoy the last months of his life. They and me as well could not have imagined this when the care just started. My experienced colleague told me that she finds care for terminally ill always beautiful, fulfilling care. This was for me a time where I started to realize what I can mean as a nurse for somebody. We get the privilege to help somebody when they need it the most. So I agree that the work of nurses is emotional labor. But I don't agree that it's depleting. For me, the fact that it brings up emotions is a sign that it's very valuable work where I can be proud of. I have to say that for me it could become too heavy when I only needed to provide palliative care. Fortunately, as nurses, and especially as district nurses, we can and should be generalists that can deliver various types of care. So most of the time, after I visited this terminally ill patient, I had to go to another patient, to an older lady with light dementia. And that lady always had a smile when I came in the door, which made it for me easier to put everything in perspective. Thank you. And that was for me, and now I want to hand it over to Judith.
Okay, Judith. Judith is going to talk, and thank you, Joost, for this very nice, beautiful, intimate story you experienced. And I think most nurses who start working as a nurse have these kind of experiences, and that's why we feel that our work is so meaningful. Judith is going to talk more about the circumstances and the team, I presume. Judith, for you.
Yes. Thank you. Good evening, everybody. Thank you for having me. I'm speaking from Arnhem, the Netherlands, and my name is Judith. And 9 years ago, I started as a community nurse at Buurtzorg. In recent years, I have been able to experience the positive aspects and challenges of working in a self-managing nursing team. With regard to the positive points, I experience a lot of energy in the work. As an extension of the challenges, I also experience stress sometimes, which in my opinion makes sense, and this is part of life. I get a lot of energy from working with my direct colleagues, in recent years, our team has grown to 10 employees. They have their own qualities and personality. And we have divided the roles in our team effectively and evaluate at least once a year whether the division of tasks is still in proportion. And if necessary, we discuss this more often. When a colleague is challenged privately, for example, due to a divorce, an illness, or another life event, the other colleagues take over some tasks. With the team, we are in control of important general tasks. We keep an eye on our productivity as well as our care hours and whether or not the care hours are in proportion to our contract hours. This contributes to our resilience as a team. It feels like our team is running a healthy company on our own, which gives us a sense of solidarity and provides us with a lot of positive energy. If there's a disagreement or another problem in the team, we can approach our team coach. This is important for us to function properly, that we feel supported initially by each other and possibly by the coach and the head office. It's about the feeling that I don't have to do all the difficult things on my own. Being sincere and humor is also vital to our team. It's important that you can be who you are and that your opinion is heard. If this isn't possible, then we must pay extra attention to this. In addition to this, a little bit of humor and being able to look at a situation lightly is evenly as important. All of our team members have sense of humor, and a good team composition brings out the best in every colleague. Also in palliative care, there is laughter with the client and their family. One of our goals is to really get to know the clients so that you also know how to approach the situation, and clients also feel free to tell us what they want and make jokes. Yes, there is emotional labor, but also sincere laughter. The point is that I can talk with my colleagues about all the things that keep my mind busy, and sometimes we need to laugh about it. Next to the team tasks, I have always felt the need to develop myself and to step outside my comfort zone, because that's where you learn the most. I secretly like a little bit of stress that comes with this sometimes, because when I have overcome this, I feel even more valuable afterwards. After working as a district nurse for 2 years, I was given the opportunity to do the master to become a nurse practitioner. This was a tough master that was accompanied by stress, and I had to adapt a lot, but I still benefit every day from what I've learned there and how I can use this in patient care and as a project employee. My idea is that my well-being and job satisfaction as a nurse depends on what choices I am able to make and my own mindset and how I view the things I am confronted with during the day, when needed with help from my colleagues. The knowledge that I can count on the support of my colleagues and my employer means that I do not have to shy away from a challenge. The mutual attention for each other's well-being ensures that we could and should rest in time. It supports me to take good care of myself. That's what I wanted to say about my experience in my team as a nurse.
That was great, Judith. And I think what Joost and Judith just said is the experience of I think many nurses who are working and living almost in this environment. So because it's I think that your intrinsic motivation, your motivation, why do we become nurses, and how can we contribute to the lives of people, and how can we support each other? These are the main elements, I think. So to all the governments in the world, I should say, just give us the time and the environment to work for, and you will all feel the profit from it. So this was what we wanted to say about the things we were just posed by Pam and her team. So I think it's very clear that we don't agree. We disagree. We think that being a nurse is the most beautiful profession in the world, very meaningful. And of course, We need to take care for ourselves, and we need to take a position. And I want to close our statements with saying that we're also starting a movement in the UK. So if you want to look at it, go to Buurtzorg, Britain and Ireland, and find out how we can do this together. Okay, then I hand over to André, I think. Yes, André. Okay, thank you very much.
Thank you, Joost and Judith. Thank you all for your amazingly powerful and persuasive presentations. I really have truly enjoyed listening to every one of you. Thank you. We're going to take a short 2-minute comfort break now. During that time, please post your questions if you haven't already done so. And remember to like the questions you'd like to hear our panel respond to. Thank you. And we'll reconvene at 2 minutes to 7 UK time. That's 18:48 UK time. See you then. Bye-bye.
Welcome back, everybody. Thank you for submitting your questions. We'll see how many we can get through in the next 10 minutes or so. So can we invite the panel of speakers to turn on their video? Thank you, Pam. Welcome back. Are you with us, Josh? Josh, lovely, thank you. Fantastic. Okay, so we said we would take the questions from the top, and the most popular question is my first one. Where does the responsibility lie for developing resilience? With the individual or with the organisation? Pam, your team, would you like to respond to that one first?
Yes, I'll begin, and then I think the team can contribute. I think we showed it's both, but without the system to support the resilience, the individual can't do it on their own. And I think Garode gave examples of systems that can support nurses to develop resilience, but they can't do it alone. It has to be built in within the system. Garode or Danny or Radha?
Yeah, I absolutely agree with Pam, and I think that we need to be really wary of the word resilience, and in some ways it's kind of insinuating that individuals are at fault for things that are structural, and until we change the systems and fix that, resilience training is just throwing plaster up against a random wall. It's not going to stick.
Thank you, Pam. Jos?
Next question.
Yes, I think that Judith said something about resilience. I want to start giving my opinion about this, because I think it's not black or white. You always have some opportunities, some possibilities to improve resilience. So I believe you always have to start with yourself and also take care for yourself. So of course, we are working in systems which are stimulating or not. I think most systems are quite frustrating. But I think if you have your colleagues, you have your environment, your daily practice, you can find ways to create resilience. And I would like to hear from Judith and Joost how they experience it in their daily work.
Yes.
Judith, you first.
Yes, yes, I said something about it, that because we are with our team in control of important tasks, it contributes to our resilience, because there's no manager who says to us, you should do this at this time or so. So because we experience the own responsibilities, and yeah, we are free to make the choices by our own, and we know what we should do because we are nurses. We know the best what the patient's needs. Yeah, that contributes to our resilience.
Thank you.
Okay.
Yeah. Oh, I completely agree with Judith. And I saw somebody in the chat saying, is resilience a way of avoiding the real issues? And for me, I think it's not. It's by building resilience, you could, you don't have to avoid the real issues, but you could deal with all the issues you come across.
Thank you. Thank you.
Let's move now to our next question, and I think this will be a question that needs to be answered by both teams, so start to get your answers ready. I'm going to ask Jos to address it first and his team. What can be done to enable governments to value the caring economy?
When I started with Buurtzorg, I decided to more or less fight the government with its own weapons. So most systems are financially driven. So I wanted to show by focusing on the professional ethics, it is financially much more attractive to work this way than the old way, as I call it. So I did a research with Ernst & Young and later on with KPMG. So I showed them that it's not soft. It's not soft, it's real. It's talking about interventions and talking about nursing interventions is real life. Everybody experiences it. And at a certain moment when I was talking with ministers in the government, few of the ministers, or I think half of the ministers, were one way or another facing healthcare problems in their families, and we have to deal with the system themselves. And I really know that there were a few ministers who had support from Buurtzorg and experiences as quite different as what they expected. And that was very helpful. But I was always trying to find a dialogue. So finding a dialogue with the government, not only opposing, but also giving alternatives. So I think that was really helpful. And what was important in Holland in 2007 is that the Minister of Health became an ally. So she just like what we're doing now this evening, I invited her to talk with the nurses, to listen to their stories, to try to understand what it means in daily practice. And the same day, the same evening, she posted on her blog, this is the reason I went into politics. So I think building relationships, not only with patients, but also building relationships with politicians. They are real people and they want to do good things too.
Pam, would your team like to come in now after that?
Yes, I'll begin and the team can also contribute. I think it's really, really important. We have to look at political leadership. Nurses have to be at the political table. We've seen the issue around the briefing during COVID. Our CNO isn't there. I understand that in the US, Biden is assembling his COVID team, but as of yesterday, there was no nurse there. So it's really important that politicians recognize the contributions of nurses. And I think one way that is being done is by such reports as the Triple Impact, which was an all-party government report from the UK, supported by Nigel Crisp in the House of Lords, which actually led to the Nursing Now campaign, a global campaign. So I think it's really, really important. Yes, we need to be political, but we actually have to see ourselves as a global force across the world. So I agree that we need to negotiate with politicians, but we also have to show our global force as nurses. And I think Nursing Now is one way of campaigning for that.
Thank you, Pam.
And the next question. What are the barriers to enable time for clinical supervision or reflective practice being part of the way that all nurses work? Pam, would your team like to take that first?
Yes, I think we have already begun to answer that. I think it was something that Garode talked about again. Danny and Radha, do you have anything that you'd like to say about that?
Yes, I personally, being a nurse has given my life purpose. However, I believe that the lack of recognition of the associated emotional labor has contributed to the depletion in different levels. As an assistant professor, as a clinical nurse, and even in the ministry, we need to do different coping strategies. So actually, in terms of supervision, we supervise students in very critical situations, and actually we don't have any support. So maybe Gerard can say some words about it.
Yeah, so I suppose currently clinical supervision isn't costed into staffing levels. When we talk about safe staffing, I think that we're very focused on numbers, but actually we need to think broader than that. Safety is relational, and it's about people feeling safe in their workplace. And until we start thinking like that and costing these things and including these in our calculations and showing the costs of these to managers in terms of sickness and burnout, I think that's how we do it and how we embed it into everyday practice, and that we are freeing people up to go, and people aren't feeling guilty that they're leaving the ward to go for supervision. It's absolutely essential for safe and effective practice.
Thank you. Can I pass that question over to Jos? How do you build that into daily working life, clinical supervision?
Clinical supervision. Judith, I pass it over to you. You have studied as a nurse specialist. What do you think about this question?
Yeah, clinical supervision. I'm a community nurse, so the word clinical is a bit strange to me. Yeah, when we have to give supervision, we go with each other into the community. When we have a student or a new colleague, we go together, and yes, we learn the highlights of the job and of Buurtzorg. And yeah, it's personal how the supervision should look like, because every person is different. So we have students and they need a lot of supervision, and they go with me for a longer time, or sometimes they have lots of experience, and then we can let them work themselves. So that's also something we decide ourselves. It depends on the person I work with. And sometimes I go with the student from another neighborhood. I go with her into the patients. So yeah, it's not always that she comes with me. Sometimes I go with her.
Thank you.
It depends on the situation.
Thank you.
Perhaps I can add to that, Judith. Thank you very much, because that's what I wanted to show, that, and I hope that Joost agrees, that it's based on the needing principle. So we say everything what we are doing as nurses, you should do what's needed, and you should take the responsibility and create the circumstances to do it. So every team has its own patterns. So we don't say you should do it this way or another way, but you find your own way, and supervision is very important. But intervision, usually we call it intervision, is something which is happening every day. So if you have a case which is creating emotional labor, the topic that we're talking about, then at that moment you find a colleague and you talk about it. And you talk about this case in a way that you say, okay, have we done the best possible things? What can we learn from it? And how can we support each other with the difficult choices we have to make sometimes? So stay close to the practice, and based on the practice, do what's needed and create intervision, supervision, the things what you think from your profession, what you need.
Yes, now I understand also. I was talking about intervision.
Yeah,
I was talking about supervision. It's a bit strange in Dutch. We call supervision like coaching trainees. Yes, sorry.
I also think because we work in quite small communities, and we work very closely together with the GP. We have a very good connection with him, and we can always ask the GP to supervise if necessary. So the lines are very short. So if necessary, it's always possible to discuss a patient's case with the GP.
Thank you. I think listening to Jos and his team, it's the autonomy that these nurses have that enables them to find the space for clinical supervision. Thank you very, very much. Thank you. Andre.
I've just noticed a comment flashing through my screen, and it said intervision is the new vision. So thank you very much for introducing that word to many of our vocabularies. The next question, I think, is directed directly at Jos and your team. It's Buurtzorg was founded on and led from values that support professional autonomy for nurses. The organisational structure and culture grew from this. How can current organisations founded on a different set of values with resultant structure and culture, transform and enable professional nurse autonomy?
Yes, I should almost say go back to the roots. Every time I'm in the UK and I'm talking with leaders in the NHS, I'm surprised that there is so much experience and so much knowledge about this. So sometimes I think we should just turn the button the other way around. I think we share the same experience, and to create a transition, I think the first thing we need is to have the conscience and the awareness that it can be done in a different way, and that we perhaps made some mistakes the last 10, 20 years in the changes we made in the system. And I think, and that's really different than in Holland. And in the UK, you just see that there are a lot of nurse leaders on all the levels in the system. And I think they should come together. They should create a kind of a coalition of the willing, and they should create kind of experimental environments where you can show that it's not so difficult to do it in another way. What I wanted to show in Holland was if you just build on these values and on these principles, that it's very easy to go on. And you know, these in my opinion, what I found as a nurse is that they are very human principles. Taking care for people is very human, it's very normal, and we should make it the most important value of society. So in my opinion, I can talk about strategies and I can talk about a way to transform, but it starts with the awareness and the consciousness that everybody can have a part in this, and that if you create a coalition of people who are doing this together, you can start a movement. And I believe this can be done everywhere.
Thank you.
I'm sorry, I'm not very concrete, Andre, but this is what I think about it now.
Very helpful, thank you. And just to draw your attention, everybody, there are lots of answers going into the chat box and further questions as we're going on. So what you're all saying is very stimulating, and everybody's enjoying it. So next question over to you, Anne.
Is this our last question, Andre?
I think it will be.
I think it will be. So I'm going to bridge this slightly, and if we could have quite succinct questions, answers, please, from each panel, that'd be very, very helpful. So this is from Chloe, and Chloe says, could we say nursing work is inherently traumatic, and systems put the onus on the nurse to manage their well-being when the system really should be taking responsibility? Pam?
Yes, I think that's what we were saying. Emotional labour is both a joy and a burden. When the systems are in place to support that emotional labour, then nurses can care and be supported to care. I'd like to make a point about the COVID-19 pandemic and many crises in which nurses have been at the front line, in the different wars, in the different epidemics, in Africa, in China, to just show what work nurses do and that they should actually be recognised for that work, and it should take them forward.
Thank you, Pam. Jos?
Yes, I really want to say, I saw some comment on who is the system. And I really would like to say, we are the system. So we are part of the system. So we should personalize, I think, what the system is about. So what I did was just taking my phone and send a message to the Minister of Health when I disagreed with something. So I just had a phone number and I said, what you're saying is not true. Or can you perhaps do something to help me with this and that? So what we should do, I think, is to try to personalize the system to see, okay, we have ministers, we have the inspection, we have all kinds of stakeholders in the system, and there are people behind it. And these people have a job, a name, a life, and a family, and they are also part of what we're doing. So for me, it's always very helpful to see the system not as something abstract, but something as done by people. So, and try to address the topics to people instead of to the system. Because I think the system is nothing, or it's everything, you can say. So, and we should, as a nurses, I think but I already said, we are able to heal the system. So we should take our own profession very seriously. We should say, who understands the pain, who understands the mourning of the system? We as nurses, we can do amazing things when we take the responsibility. And that's not easy, because that is going with all kinds of frustrations. And so, but I really think that's the beginning of the change. So nobody is guilty. Nobody is guilty. This is what happened. It's based on a history, and we should change it for the future. So we are building a future. So I'm very happy that Judith and Joost are here, because they are the future. They are going to build a much more healthy healthcare system than what we had the last 40 years. I'm convinced.
Thank you. Thank you. Andre, did you want to come in here?
Yes, thank you all very much. I've just been running through the questions. There are many, many, many questions that we can't answer tonight because we've run out of time. Thank you so much for your attention and your interest. We've got other things we need to do, like voting on the motion in the last few minutes. So we will actually work out a way to take forward the questions that you've asked. And we'll put up on our various websites, the Foundation of Nursing Studies and JRN, the ways in which we will carry on that debate, because it is obvious that it needs to carry on. So thank you. And just hand over now to my colleagues.
Thank you, Andre. It's Joanne again here. So thanks, everybody. Thanks for your questions, and thank you dearly to the panel for their responses. I'm now going to ask Lou to run a second poll to see if there's been a shift in our collective opinion as a result of this evening's debate.
And the poll is just relaunching. Bear with me just a second. You should see it any minute. Okay, can people see that? Yes, so if after hearing our debate you agree with the motion, then please vote yes. And if after hearing the debate you disagree, then please vote no. I'm just going to leave it a few more seconds. Okay, I'm going to end the poll now, and I'm going to share the results. Okay.
Thank you, Lou, and thank you, Joanne. And thank you, everybody. Thank you for the wonderful questions that you put forward this evening, and to our panelists for a very, very stimulating debate. We're really, really sorry that, as Andre has said, that we haven't been able to take more of your questions this evening, but we do commit to theme them and look at some creative ways of how we can continue this conversation, because it's too important to stop now. So thank you. It now gives me very great pleasure to hand you back to David for his closing remarks. Thank you.
Thanks, Anne. Well, what an extraordinary discussion. That's been absolutely wonderful. The eagle-eyed amongst you will see that at the start of the evening, there was 65% for the motion and 35% against. That has now drifted, I'm not sure it's a swing, but it has drifted to 55% for the motion and 45% against. So there has been some persuasive argument in favour of the fact that nurses' well-being can be protected. We've had some extraordinary presentations, and just to pick up a couple of points, because I couldn't possibly summarise it all. I think the first thing that struck me is that we've heard some very personal and persuasive arguments, particularly using personal stories from Danny, Radha, Just and Judith. And it's the power of those stories that is really important, because experience is evidence. We've heard more about empirical evidence from Pam and Jos and Garode. And some of Garode's words around nurses being the face of the system resonated enormously, as did Jos's reference to the introduction of public management, new public management in the 90s, to which I was around to experience. So the importance of relationships has come up from both teams. The importance of nurturing and coaching the new generation is important in how we give nursing care, how we manage nursing work. I think one of the most striking things, though, is that we hear a lot about nurses pleading to be empowered. Well, perhaps you can't empower someone else. They have to take that power for themselves. Where from the team in the Netherlands, we've heard that they've created the new system. They've taken the power. They haven't waited to be given it. No one's going to issue a gold-edged invitation to come to the table. You have to get there by your own means. And I think one of the important things that Jos said, amongst many important things, was having an ally who's not part of the nursing family. And I think that resonates with experience in the UK, where we want to make policy changes and it's no good nurses talking to nurses. You need another ally, and the politicisation of those arguments is really important. But when it comes to this evening, it never occurred to me that we would have such a widely diverse discussion with a huge number of questions and very lively chat, even with Newtonian physics thrown in. I didn't expect that one. So thank you all very much for this evening, particularly to the panelists. They put a lot of time and effort into preparing this, and have presented beautifully. So Pam, Garode, Danny, Radha, Jos, Just and Judith, thank you all very much. Thank you all also to those behind the scenes. We haven't seen much of Joanne or Lou, but they are there working away very hard. And you won't realise what internet problems we've had previously in rehearsing for this, and it is by sheer willpower that Lou has kept the system going single-handedly, so thank you very much, especially to her. And the organisers in pulling this together, what an absolutely marvellous job. It's worked seamlessly, so well done and thank you. And we really must do something with the outstanding questions and the comments in the chat box that lend themselves to doing more work around this particular topic. And I think it's an extremely important thing to have done. It's, I hope, one of many of these discussions. And it just leaves me thinking about today in particularly, because it is Armistice Day and we have had a day of remembrance. And we've remembered those in the armed forces and civilians who sacrificed so much for our peace and freedom. So I particularly wanted to take a moment now to remember those who contributed and sacrificed themselves, who were nurses during the times of conflict. It's really important that as we recognise these points of remembrance throughout our lives, that nursing has made a particular contribution. So thank you to all those people. On that note, I think it's timely to close the meeting and just hope that we will do this again some other time. So thank you all very much.
Thank you.
Thank you, everybody, and good night. Quickly, all the panelists come up and we'll just say good night to everybody. Our time is up, absolutely spot on, 7:30. We're so relieved that we stayed with you and we didn't have to do any of the dreadful things we anticipated with technology. Thank you, and good night from us all. Good night.
Bye, everybody. Thank you.
Bye. Bye.
Thank you.
Bye.
Bye.
Bye. Bye. Bye. Bye.